Thank you. Though it's the last session, difficult to concentrate, but I would like to request you all to concentrate for next 10 or 12 minutes. Hope we will have some brainstorming and we will discuss about the difficulties, dilemmas, and decision making that we all have in our clinical practices. I am Ghulam Mahmood Raihan from National Liver Cancer Institute, and this is a presentation I have made with help of my colleagues, and here are their names. So, I have no conflict of interest to declare, but in my presentation there are some real patients' name and ID. Please don't use them for your reference. So there is a little bit of personal history behind that. Last year I was a fresh master's from hepatocellular surgery with lot of theoretical knowledge in my head, with lot of protocol and with lot of protocols and lot of guidelines. But then one of my very close friends' father came to me with some weakness and loss of appetite. And I have gone through some investigations like triphasic CT scan of the abdomen, and also alpha-fetoprotein was done. And both were normal. So I think it was a bit like elderly and the late age problem or something like that. I prescribed some vitamins and do some counseling to boost up his morale. But after 1 month, his condition was deteriorating. And then he visited one of my teachers and he did a contrast MRI. And as alpha-fetoprotein was normal, he did PIVCA2 that was very limited in our country in perspective of availability. And you can see that alpha PIVCA2 was more than 30,000, and the contrast MRI was shown multifocal ACC, and he passed away just after 6 or 7 months. And that struck in my mind. So there is some difference between our theoretical knowledge and the difficulty we face in our clinical practice. So my first case, he was 77-year-old male, non-B, non-C case, and he came to us with this type of imaging, and you can appreciate that there is an heterogeneously enhancing lesion in the segment 6, and also the CT angiogram shows there is a very good lesion for resection and very lucrative for surgeons like me. But he had an FNAC that you can appreciate that there are it was suggesting that it was an hepatocellular adenoma. So FNAC was not conclusive, and so we did the resection, and the final diagnosis was hepatocellular carcinoma grade 2. But interestingly, his alpha-fetoprotein was also normal, but PIVCA2 was slightly raised. So CT scan finding was more convincing than the biochemical markers in this case. And so now come to a female patient who is 65 years old, also non-B, non-C patient. And he has the imaging like that. There is lesion in segment 6 and segment 7. And your report says there is a SOL in both lobe of the liver, in right lobe of the liver, and possibly HCC, a very good case for hepatobiliary surgeons to do resections. But in this case, his alpha-fetoprotein was also normal, though the lesion was big, but PIVCA2 was 15,000. So alpha-fetoprotein could not conclude our diagnosis, and we have to take help from PIVCA. And also the confirmatory diagnosis, the resection histopathology, it was suggestive of hepatocellular carcinoma. So now we take a case of HBV positive case, that is the most prevalent cause of developing HCC in our country right now. So in this patient, he has a very good imaging, but the contrast uptake characteristics were not typical. There was no early washout. Okay? So the CT scan comment was like something lesion like hemangioma. But we thought a patient with 45-year age with HBV history. So and his alpha-fetoprotein was normal, but PIVCA2 was 26,000. So we did a contrast MRI, and there was no bulb sign. Rather than it was suggestive of hepatocellular carcinoma. So I think from the first 3 cases, we can draw the inference that alpha-fetoprotein or ultrasound that can't conclude or that can't comment whether there is HCC present or not. We can do further investigations like PIVCA and somewhat we have to take help from further investigations like contrast MRI. So our diagnosis is complete, and our surgeon's next question, is it resectable? So as we all know, the CT scan is the gold standard for diagnosis of the resectability. So this is my case 4 for you. There is a very lucrative lesion for the hepatobiliary surgeons, and every hepatobiliary surgeon will decide, okay, let's go for a right hepatectomy in this case. And also alpha-fetoprotein is raised and it is 241. And you can see that the patient is a very high viral load. So hepatologist can do us some help by giving some antivirals. But when you go for a contrast MRI, you can appreciate that along with the right lobe lesion, there is also a lesion in the left lobe. So now the case is unresectable, though it was from the CT scan seems like we can resect and we can go for a very good right hepatectomy. So, and you can see that in the CT report, it demonstrates the lesion is only in the right lobe, but MRI has called the lesion is in the both lobe of the liver. So that tumor that was initially resectable in CT scan is now unresectable after doing the MRI. And my fifth case, now a very good case for left hepatectomy for hepatobiliary surgeons. I think you all appreciate that. And there's the left lobe lesion. But from our previous experience, we also have seen that there is a very raised alpha-fetoprotein more than 1,000. And when we have gone through an MRI, we can see there is lesion also in the right lobe that was not demonstrated in the CT scan. So CT scan can't conclude all the lesions. And before resectability, in suspicious cases, we have to perform an MRI to decide whether we will go for a resection or go for other therapies. Now, my sixth case, I think you can appreciate that there is a lesion in the mainly segment 6 and partly segment 7. So, okay, so surgeon, I think most of the surgeons will give their opinion, it's a resectable case. But when I go through the CT scan report, they told there is also a short segment thickening with luminal narrowing in the ascending colon. So they suggest that the lesion is possibly metastatic adenocarcinoma in the liver. So we do an endocolon, and endocolon was normal. So what next? Okay. Then we go for a MRI. And MRI said there is no lesion in the colon or abdomen, and they advised us to do a CT scan that is already done and non-conclusive. So we go for a true cut biopsy that you can see in the left side that was suggestive of metastatic adenocarcinoma, but there was no primary. We could not find out whether if there is any, so we go for immunohistochemistry, and that was suggestive for hepatocellular carcinoma. And so our diagnosis is now confirmed. So sometimes we cannot conclude with the histopathology report. We have to do immunohistochemistry report. Okay, now can we play a reverse game? Okay, now our reverse case is the case 7. It is a very young boy of 24-year-old. He came to us with pain in the upper abdomen and this type of lesion in the left lobe of liver. And you all know in a non-B, non-C patient at this age, this type of lesion, we rarely think of any type of hepatocellular carcinoma. Am I right? Okay. So CT scan also could not conclude, but there was also an abdominal lymphadenopathy. But interestingly, you can see on the right side, the alpha-fetoprotein was more than 300, and PIFCA2 was also raised, is more than 250. So what's your diagnosis? Okay, whenever surgeons cannot make the conclusion by investigation, they do the surgery, and we also did that. And we resect the tumor, and the paraoperatively, you can appreciate that there is a puckering or stricturing of the surface capsule of the liver. And though the also histopathology report came in favor of hepatocellular carcinoma, but you can see that the background liver parenchyma is too good to be HCC. So we go for a immunohistochemistry, and this time it came for intrahepatic cholangiocarcinoma, and we conclude our decision in favor of intrahepatic cholangiocarcinoma. So my last case is a little bit more confusing, okay? So whereas we have to defy both the immunohistochemistry report even. So can you see this CT scan image? The non-contrast film on the left side have some calcification in the center. There is a big lesion in segment 6 and 7, and there is heterogeneous enhancement after giving the contrast. And this is also a very good case for hepatobiliary surgeons for planning right hepatectomy, and this case actually referred to me by my oncologist friend after doing all the workups, and he sent me just do a right hepatectomy. So I have gone through the reports, and there is a large growth in segment 6 and 7, and the CT scan report said it was HCC right lobe of the liver, alpha fetoprotein was normal, PIVKA2 was normal. It's not the end. The patient also has done already true cut biopsy. True cut biopsy was in favor of HCC, and immunohistochemistry was also in favor of immunohistochemistry, in favor of hepatocellular carcinoma. So we were a bit confused, and we went for an MRI. And in the MRI, you can appreciate that those surgeons, there is a very big lesion in contact with the right kidney and depressing the right kidney below. So is it an HCC, or we have the second diagnosis, it may be a case of adrenal tumor. Though we already have the immunohistochemistry report, we already have the histopathology report. So we go for resection, and actually it was an adrenal tumor. When we entered into the abdomen, liver was absolutely okay, and there was a big adrenal mass, hypervascular. We resected it, and actually it was an adrenal mass in the biopsy. So always don't believe all the reports in your hand. So at the end, I have to draw the inference. I think it's better to say actually 80% cases are always be typical, but 20% case will always be exceptional, that you have to think and you have to use your brain, and sometimes you have to use your instinct. So never hesitate to go for further investigation until diagnosis is confirmed. Because sometimes we consider that patient is poor, patient don't have money, whether he will say if I write very expensive investigation, but always some extra cost is better than missing the diagnosis. And we have to always remind that real life scenario is much more different from textbooks, from the protocols, because truth is always stranger than fiction. Thank you.
Dr. G.M. Raihan, I think he stated the case series is, and we have learned a lot from him. And we know that the good surgeon know how to cut, the better surgeon knows when to cut, and the best surgeon knows when not to cut. So আমরা যদি জানি যে লিভার ক্যান্সারের আমাদের ইন্টেনশন থাকে যে কিউরেটিভ ট্রিটমেন্টের মধ্যে লিভার রিসেকশন করা যায় কিনা অথবা অ্যাবলেশন করা যায় কিনা. So this is our intention, to treat the patient with surgery. And if not possible, then we go for local regional management or other like immunotherapy or TKI. So thanks all, thanks our dear participants for a huge number present in the last session. Thank you all.
Dr. G.M. Raihan for his very nice and problematic cases presentation, because sometimes clinically and by one investigation we think one diagnosis, and ultimately after further more extensive investigation the diagnosis is changed. So he has given us hope that go on investigation and find out the real cause of the illness. And I like this presentation.